I'd like to thank Boston Scientific for inviting me. They asked me to present a case. This is a case, but it holds a message. And I also would like to thank and congratulate Professor Sofhi on the success of CardioAlex. Every year is better. And finally, last but not least, to thank Eric Thepaut for taking time and coming here. Should I worry about the stent and the drug on it, or should I worry about my patient? In the increasingly complex world of angioplasty, we actually need to focus on one important component, which is the patient. In my case, which I only did last week on June, whenever I present a case, I try to bring a new one. On June the 1st, 2011, is a 60-year-old lady. She's obese, 110 kilograms, and not a very tall person. She's a heavy smoker, heavy cigarette smoker. She's hypertensive, she's non-insulin dependent diabetic, she's dyslipidemic with a very strong family history of coronary artery disease. She presented with acute coronary syndromes and dynamic ECG changes with transient marked ST depression. Her troponin was elevated, normal MB. She was admitted to another hospital. She was managed well, conservatively, and was transferred to our hospital free of chest pain, stable and smiling. She received standard treatment for acute coronary syndrome on admission. She had been loaded with 600 milligrams of clopidogrel before coming to our hospital. So we immediately performed, as in the patients in whom we suspect, like a diabetic lady like this, obese lady, we performed a verify now test to see if she was clopidogrel responsive, and we were disappointed to find that her PRU was 297. If it's above 240, then you're not adequately. So she had inadequate platelet inhibition by Plavix, and this was my concern. We took her to the cath lab, gave her weight-guided heparin, and transferred her to the cath lab. My first concerns were inadequate platelet inhibition. I was also worried about an increased risk of bleeding. She's obese, diabetic, female. She was also very anxious, and I knew she was going to move a lot. She initially actually refused to even have a venous cannula. We decided to access her via the right radial artery, which Jose Diaz has actually established in our center, under heavy sedation with the help of an anesthetist. This was the first angiogram, and you can see that her LAD is very critically, this is her second. Her LAD is a long calcified lesion, and her circumflex, I don't know if, circumflex had something here, which I wasn't terribly sure about. So anyway, it was obvious that we had to start with the LAD. She had a lot of calcium. Here I had two more concerns. One was the calcium. What is the calcium going to do to the procedure? And the other one is, I was hoping that the LAD was the culprit one. I wasn't sure if that's her, because her ECG had changes, extensive changes in the anterolateral segments. Anyway, we were ready with the cutting balloon and with the rotablator, but decided first to take a compliant balloon and just feel the lesion, and indeed that was the first inflation, but it did crack at a pressure of 16 atmosphere. It was a 2.5 by 20 balloon. We performed more free dilatation to prepare the lesion, and it was dissected. This was the first stent, which is a PROMIS element, 2.75 by 24, deployed at 14 atmosphere, and then used the same balloon, which is a very easy to use balloon, to do further post-dilatation using a bigger balloon in the proximal lesion. So this, it looked good. I'll play it again. I thought this distal part of the lesion looked good. We then put a 3.5 by 28 stent covering the proximal part. It was slightly longer than I would have liked, but anyway, it was deployed. And then the same balloon was very easily pushed forward to dilate the part between both balloons at 18 atmosphere, which is one of the advantages of the delivery system of this with the Apex balloon, is you can actually, once you deflate it, it can still go through deployed stents very easily. You can take it to 18 without any concerns. So I was hoping not to post-dilate. And then I even used it to post-dilate the lower stent without sticking out of the edge. We then had this angiographic result. I was very happy with it, but of course, I know very well the music criteria, and I know that in this calcium, there is a chance that the LAD stents are not optimally deployed. So my third concern was, were the LAD stents optimally deployed or not? So we went for IVUS, and we found, I did not have the IVUS runs to load, but I'll show you a few still pictures. We found that there was severe under-deployment at the focal point here before the end of the last stent, and at the point of overlap. Both those points were poor, and the diameter here was 3 millimeters. So we brought a 3 by 20 non-compliant balloon, quantum non-compliant, and went up to 26 atmosphere in this part, and also did an inflation at the junction, but the junction we know is bigger. We then did another IVUS, and indeed the lower part was satisfactory. There was still preferential stent expansion, but I don't think you could do anything more about it because it was very, very adequately deployed as far as having no malapposition. But we had, at the junction between the two stents, we had this small area of malapposition. So we brought a 3.5 by 20 balloon and took it up to 20 atmosphere exactly at that junction with more inflation in the proximal segment just to optimize the stent. We then did a last IVUS, and it was perfectly deployed all through, apart from the very distal part with massive calcification, but which was satisfactory. That was the end result, the angiographic end result of her LAD, and it was very satisfactory. We then went to the spider view, and that's what we found. I'll play that again and freeze. The circumflex is really critical, calcium, possibly even a filling defect. It was wired, was ballooned with the same 2.5 by 20 that we used for predilatation, and it received a third PROMIS element stent, 3.5 by 18 atmospheres, and what looked like perfectly angiographic result, and I wasn't, I did not even bother to IVUS that. It's a single stent, it's short and went to very high pressure, and one of the nice things about this stent, if you look well, is you can actually see, without contrast material, you can see the stent very well. And I know it doesn't project on the large screens, but the main reason I kept IVUSing the LAD is I could see that there was a point in that stent which did not look as good as the rest. And that is not the case with other generation stents, which you can't see them very well. So what are my concerns for this patient? This patient was clopidogrel resistant. We had reloaded her with 8 more tablets, 600 milligrams pre-procedure. And 2 hours post-procedure, we retested her by Verify Now, and unfortunately, her PRU was still very high. So this patient was now officially Plavix non-responsive. She already had 3 DES. I had deliberately not given 2B3A blockers because she was already clinically stable, and if I had given 2B3A blockers, I would not be able to retest because the integralin would make the test non-valid. So at that point in time, I decided that this lady was going to go on prasugrel. So I started her on, which is immediately post-procedure. She was very stable on double bolus integralin, kept her in hospital for slightly over 24 hours. During that time, we have our channel by which we get prasugrel for our resistant patients consistently. And we got her the prasugrel. She was given 80 milligrams of Efient, 60 milligrams loading, and discharged on 10 milligrams daily with aspirin. What were the other concerns? Increased bleeding risk was a concern, so we went radial and we used weight-guided heparin, and we used ACT every hour of the procedure. It took slightly over 1.5 hours. We protected her kidneys because her creatinine was 1.7, so we hydrated her and used isoosmolar contrast. She was very irritable, so we used Deprivan, which is propofol, the drug that killed Michael Jackson. She had very heavy calcium, So we used adequate pre-dilatation. We were ready with a cutting balloon and rotablator, but we didn't need them. We were worried about suboptimal stent deployment because of the calcium and the long overlapping stents, so we used IVUS and post-dilatation. And of course, I just told you the story of our clopidogrel resistance. I was also concerned about having an undeliverable stent or suboptimal imaging where I couldn't see the stent because of the calcium, or having stent fracture due to the high pressures I was going to go to, or having poor stent expansion once I put it, or having dog boning at the edges leading to edge dissections, or having fear of increased late stent thrombosis, or having a bad balloon which doesn't go through. And actually, I dealt with all those concerns by using a PROMIS Element stent in an IVUS-guided fashion, because it actually deals with all those questions. And my point is, this is when I was coming to Alexandria, and on the desert road, the first thing is people were driving on the other side of the road, as you just showed. So one of the concerns which we have in driving in Egypt is things that can happen which are so unusual, like a trilla and the guy who's driving opposite the other side of the road. And what I need is I need to focus on the road. I don't need to focus on other things which can distract me and result in a disaster. And just like driving on an Egyptian highway, where I need to focus on the road, otherwise I may die, while doing my PCI, I have so many important issues that I need to focus upon relating to the patient, as I just showed in this illustrative case. I don't want the stent issues to distract me. So that is why I use the best second or third generation stents. And indeed, to be honest, along with the Xience Promise, the Resolute, the Nobori, and the Xience Prime, I find the PROMIS Element is indeed one of the best deliverable and one of the best visible scaffolds that are currently available with a truly superior delivery balloon. Thank you very much. And drive safely.